Okay. Okay. Guess not goofing around. Oh, tired thinking it's Friday, right? All right, so finally a chapter that you can kind of relate to. I mean, the muscle chapter you can kind of relate to, but everyone loves the cardiovascular system, so this will be kind of a fun one. I'm going to really try and focus on, I brought the breakdown, so I'm definitely just make sure I hit those hard. The others I might go a little faster on, but I just want to make sure and get those. So let's start with review. Okay. So from anatomy, here we go. Okay, number one, what is that called? That structure. It's a vena cava, but it's relation to, is it above or below? Superior. Yep. Vena cava. And then two, this would be the inferior, okay? I'll say superior and inferior. You still have to know this stuff in nursing. Two, what's that chamber called? Right atrium. Okay. And what is this valve that separates that atrium from this chamber below? Right, AV, or known as the tricuspid. Okay, and then the chamber below is the right ventricle. Good. Okay, now this valve that separates that right ventricle from this vessel right here, I'll give you a hint. It's a semilunar, that's correct, but it's named after basically where that blood vessel is going. It has to do pulmonary. Pulmonary refers to lungs, and that is the pulmonary semilunar valve. Good. Okay, now when that pulmonary semilunar valve bifurcates, the vessel, oh, I'm missing 6, hold on. Pulmonary trunk. Okay, they call it a trunk because like a tree, it's going to bifurcate. Now, when it bifurcates, here's the trick. It's not really a trick, but, oh, nope, go back. When it bifurcates and goes to the left and right lung, what are those vessels called? Ooh. They just start with pulmonary. Yes, pulmonary arteries, because regardless of whether it's the systemic circuit, not shown here, or the pulmonary circuit, which is what we're going through, arteries always go away from the heart. But in this case, the type of blood these vessels are carrying is oxygen poor. That's why they call her the blue in textbooks, because it's taking oxygen poor blood to the lungs to pick up that oxygen. So that means once it's picked up the oxygen and it returns to the heart through these vessels, those are called pulmonary veins, because veins always return to the heart. But in this case, these vessels are carrying oxygen-rich blood. Then they come to this chamber right here, which is the left atrium. Okay, now this valve, marked 10, has 3 names: bicuspid, mitral, or left AV valve. Okay, and then, oh, I don't have it numbered. Well, that's, I did, but it's hard to see. 11 will be the left ventricle. And then this last, hard to see, so I magnify it right here. That valve right there leading to this vessel, what one's that? Aortic semilunar, yes. For some reason, it is giving me a hard time. Good, you passed. So when I talk about these, later on when I talk about valve problems or heart sounds or heart murmurs, and I talk about these valves, you'll definitely know them. Okay, so circulatory system, now going through systemic, which is the whole body. So systemic basically starts at the left ventricle. So systemic means whole body. So now blood is going to the whole body. So it starts, well, actually starts at the left atrium starts, and then it goes to the left ventricle to the aortic semilunar valve, out through arteries that get ever so smaller as they get to the tissues, and you have gas exchange of tissues, and then oxygen poor blood and metabolic waste are picked up in the venous system through ever larger veins till you get to the vena cava, right? And so the systemic circuit stops at the vena cava. The pulmonary circuit will start at the right atrium, all right? So that goes down to the right ventricle, to the lungs, back again, and then to the heart. That's the pulmonary circuit, is the shorter of the circuits, all right? So this is all review from basic anatomy. I know you've had this, okay? All right, but I'm not going to ask any particular exam questions on that. It's just expected that you know that stuff. So let's move on. So this you might not have covered. And I do ask about heart sounds. As future nurses, you get into the nursing program. I know this, what I'm going to say, because I've been there and I've seen the device they have. There's 30 something heart sounds that you're going to have to memorize. They have this device and it's got 2 little speakers that you can put your stethoscope on. And there's 30 different heart sounds that you're going to listen to. And of course, you're going to be learning them in the nursing program, but eventually as a nurse, you're going to get really good at recognizing abnormal heart sounds. And that's something that you guys do, is auscultate. And there's several different important points on the chest and leading in the back. You can hear what's happening in the heart from the back. So introductory, these heart sounds, what's happening in the heart. Ventricular systole. Okay, so here's what's happening. The AV valves, tricuspid and bicuspid, have closed, and the ventricles, both the right and the left side, contract. And I'll put down here, simultaneously. That's important, okay? The timing of these events, and we'll talk about the heart's electrical system or conduction system. The timing of these events are very important. And so these heart sounds that you're listening to are very important. So when this event is happening, specifically when the AV valves are closed, that is what produces the lub in the lub-dub, 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 okay? It's the sound of those valves closing. It's called the S1 sound, all right? Ventricular diastole is when the semilunar valves close and the ventricles are filling. Filling with blood. Okay, and the sound that you hear, that's called the dub or S2 sound, is from those semilunar valves closing, and that produces an audible sound. Now, I forgot my speaker, but hopefully the speakers in this room are going to be good enough. That produces the lub-dub, 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 lub-dub that you're listening to through the stethoscope. Now, let's just test how good the sound is. Make sure my volume is turned all the way up. If you're looking at this PowerPoint from online and you have earbuds in, it'll be the best sound that you can hear. Oh, is my link not working? Go to the link. Here we go. Just take a sec. All right. Typical, right? Okay. That's the sound of the valves closing. Shut that so I don't have so many tabs going. Now, if you hear lub lub dub, lub lub dub, lub lub dub, that means one of the AV valves is not closing in time with the other. They're supposed to close at the same time. One sound, lub, clear and distinct. If you get 2 S1 sounds, it's called a split S1. That means one of the valves, the timing is off, it's not closing at the same time. If you hear lub dub dub, lub dub dub, and it'd be really hard to hear. It takes time to get practice. That means one of the semilunar valves is not closing in time with the other. That is a problem. So anytime you have that, because here's the event that's happening. When the AV, this and this valves close, and that gives you the hub sound. All right. Let's say that the mitral valve or the bicuspid valve closes a little after the tricuspid does. All right. These valves must be closed for the ventricles to contract. Well, if this valve is not open, it's not closed, still open a little bit, and the left ventricle contracts, some blood will make it into the aortic semilunar valve to the aorta, but some of it's going to back up into the left atrium because it's not getting ejected out of the heart. Okay, now there's a common carotid artery, there's a subclavian, there's common carotid. It's going to branch into a left and a right carotid artery. It's going to bring blood to your brain. If some of this oxygen-rich blood is backing up into the left atrium, that means less is getting into the aorta. That means less blood is getting into the carotid arteries. That means less oxygen going to it. Okay, and coming off the ascending aorta, not shown in a lot of textbooks, is the common coronary artery. That's going to supply the heart itself with blood supply. And so that means less blood is going to be getting to the heart with that event, with those valves not shutting correctly. All right, if the right AV valve or tricuspid valve is the one that's not closing at the right time, then when the right ventricle contracts, less blood is getting to the pulmonary trunk, less blood is being delivered to the lungs to pick up oxygen and get rid of CO2. And so these are the problems. By far the biggest problem is if there's a problem on the left side of the heart, because immediately the brain and the heart get first dibs on that blood. And I've already explained to you what can happen to the heart and the brain if they get low oxygen blood or not as much blood. That's going to be a problem. So what you're listening to, those stethoscopes and your auscultating heart sounds, it's actually very important. All right. So asystole. So I've taught you when it has the word A in front of it, what does that mean when it has A in front of it? Absence. Okay. Asystole is no heart sounds. And if you hear that, you're calling a code, getting a crash cart, and yeah, your patient could die on you. All right, asystole is bad. Okay, so it's a very simple slide, but what you guys are listening for, they're very important. Like I said, there's going to be 30 sounds, and I've got a little GIF here to kind of show what's happening. They're kind of showing also what's happening with the heart's conduction system. But the important thing, they don't show it very well, but when the atria contract, they do it simultaneously. When the ventricles contract, they do it simultaneously. That's going to have to be controlled by your heart's electrical impulse system. And that's very important. All right. The valves must shut simultaneously. The chambers must contract simultaneously. If that's not happening, you've got major problems. Okay. So ventricular diastole. The ventricles are filled with blood simultaneously. Actually, it's a passive event. Because when the atria are full, here on the right side with venous blood, and over here with basically arterial blood, when they fill up, they're in a chamber. The fluid filling the chamber causes immense pressure. And what that pressure does is it forces the tricuspid and bicuspid valves open. And they start filling. That's ventricular diastole. Then the atria contract simultaneously to push maybe the last 20% of blood into those ventricles. Now the ventricles are full of blood with tremendous fluid pressure, and the filling of those ventricles causes so much pressure it shuts the valves simultaneously. So it's a pressure event. That's what's going on. Okay, so the pressure in the ventricles from the full of blood closes these valves, but opens the semilunar valves with that pressure, and then blood starts entering the vessels. And then the ventricles will contract simultaneously to eject the last little blood that they can into those vessels. And so that's called ejection. All right, it's called, you can calculate an ejection fraction. That's an actual medical thing to determine how good is the heart functioning as a pump. All right, so that's the ventricles filling. And then the ventricles contracting is simply known as ventricular systole. All right, so before they contract, the AV valve shut, that's the love sound. Then they contract, and before they contract, they're filling the vessels with blood. Then they contract and they push the last little bit of blood they can into those valves. Vessels. Now the vessels have a lot of fluid pressure, and that causes the semilunar valves to snap shut. And that's going to be your dub sound or your S2. So I'm just explaining things to you. It's not something you can really write down, but it's something you can listen to me say and hopefully remember when you get to the nursing program and you're listening to those heart sounds. You got to imagine what's happening in the heart when I hear these sounds, or what's going wrong in the heart when I listen to these sounds. All right. So is that something that they explained in anatomy? What's going on with the chambers contracting and the sounds that the heart is producing with the valve? No. Okay. So this is the first time you're hearing it. Definitely want to cover it. I'm going to ask a couple of questions. I forget how many. Let's see. Two. So I'm going to ask either scenario. What's the lub sound representing? What's the dub sound representing? Okay. So on this slide, if you're looking at this PowerPoint when you're online, you can listen to some of the sounds, but there's an innocent murmur and there's a pathological murmur. And I bring this up because in children, sometimes they come out not fully cooked. All right. I always say that because it kind of makes me laugh, but it's true. I had an innocent murmur when I was a kid, probably 7 or 8 years old. My general physician picked it up and mentioned it to my mom, who then immediately freaked out and had me taken to all these specialists. Turns out it was just an innocent murmur, and I did outgrow it. So what a murmur is when you get a little whoosh sound between the lub and the dub, the whoosh dub, the whoosh dub, the whoosh dub, okay? And sometimes you can hear it, especially when people breathe deeply in, you can hear a sound like that. An innocent murmur is, oops, stop doing that when I touch the screen, is a quiet whoosh between the lub and the dub. It means one of the valves is not closing, probably at the tricuspid or maybe the bicuspid. But the thing is, it's innocent. It's, I'll say, common in children who should outgrow it, If they don't, then it might truly be a pathology, all right? So don't freak out if you hear that in children. If it's a quiet whoosh, if it's a loud whoosh dub, all right, that doesn't sound right. It's just a quiet little whoosh, and the child is otherwise healthy and they don't fatigue or pass out with exercise, they're probably fine. Now, a pathological murmur is a loud whoosh between the lub and the dub in adults. And I'll say comma, or abnormal. Oh, that's supposed to be an M. Abnormal S1 and S2 sounds. Okay, so this is where those 30 different heart sounds that you have to learn in the nursing program come in. Okay, and there's many different things, so many different things that can lead to a pathological murmur. But the big thing is if you hear an abnormal heart sounds in an adult, you always have to treat that as pathology. Something's going on. If it develops, they were fine when they were young, their patient history, so they've never had this problem before, but all of a sudden they develop it. That means something has happened, and that is relevant. That is significant. So here's some of the things that can lead to these abnormal sounds. Regurgitant flow is just a vocabulary word. It means the backward flow of blood. Let me be specific. Backward flow of the blood through the valves. If one of those valves doesn't close, let's say the bicuspid valve didn't close, like I was showing you or explaining before, that means when the left ventricle contracts into the bicuspid valve up ahead of it is still open. When the ventricle contracts, some blood makes it out to the aortic semilunar valve, but some is going to back up into that left atrium. And now that means your brain and your heart are going to be getting less blood because some of it was diverted back upwards through regurgitant flow into the left atrium. It's going the direction it shouldn't be going. And that's always bad, especially on the left side of the heart. So that's what regurgitant flow is. Now, aortic stenosis. Stenosis means stiffening. It means it's formed scar tissue. And scar tissue is stiff and inflexible. And these valves are supposed to be kind of elastic, all right? So they can open and shut, and when they shut completely. If the aortic valve, aortic semilunar valve, has become stiff, it doesn't close as well. And so what's happening is when the ventricles contract, some of them, not all the blood is getting out into the ascending aorta. Some of it's going to be retained in the heart. Ultimately, less blood's getting to the brain, less blood's getting to the heart. Rheumatic heart disease, it's an autoimmune attack where antibodies attack particularly the bicuspid valve. Now the bicuspid valve becomes stiff and it doesn't flow all the way. And then when the ventricles contract, some of the blood goes back up into that, through that bicuspid valve into the left ventricle, the atrium, and then only some of that blood is getting into the aorta. So again, the left side of the heart, if you've got problems with the valves, that's going to be more of a difficult diagnosis for the person. That's going to have to be, there are valve replacements. If someone's valve is not working, they replace the valves. That's how important it is, because you cannot go on very long with that problem. Okay. Okay. So let's see what an innocent murmur sounds. Let's see how our sound is for this. The second sound is the dub. The lub sounds muffled, like whoosh, lub, whoosh, dub, whoosh, dub. Those first two, the first S1 sounds, there's a second S1. There's a little bit of sound after that. That whoosh you're hearing, that's an innocent murmur. Okay, so let's go back and listen to what aortic stenosis sounds like. That's where the aortic semilunar valve is stiff. It's producing an abnormal sound. All right, and I am not trained very well for all these sounds. I know that you guys are going to have to learn them, but okay, let's get back to this. Let's hear a split S2. So there's an extra dub, and this one's hard because the two sounds are very close together. That's very hard. If you had earbuds in, you'd hear this very well. That dub sound, there's two, it's split. Okay, and there's all kinds of things like a Kentucky gallop and all these sounds that are going to be wow. All right, so that's just to give you an idea. Okay, septal defects. I ask about septal defect. Yes, I do. Okay. Babies come out, sometimes they're not fully cooked. I keep saying it. While the baby's in the womb, in utero, and mom's circulatory system is really handling all her demands for oxygen and removal of CO2 and other waste. Once a baby is born, they're on their own. Their own circulatory system has to handle it. So while they're still a fetus, there is often a hole between the right atrium and the left atrium, and that's called a patent foramen ovale. Patent means open, foramen means hole, and ovale means the shape of it. Okay, and don't confuse this with one of the holes of the skull that is called the foramen ovale. This is different. So this is a hole, I don't even say fetal, I say a hole between the right and left atria. If they're born and that hole is still there, because it's supposed to close up by the time they're born, what you have is a mixing of oxygen-poor blood with oxygen-rich blood. Okay, it's not a problem if oxygen-rich blood gets into the right side of the heart, because that's going to be on its way to the lungs anyway, so who cares? But if oxygen-poor blood dilutes the oxygen-rich blood here, then it goes down to the right ventricle, then it goes out to the aorta. That means that the brain and the heart are going to get a dose of blood that's got lower oxygen content to it. So that's a problem. Mixing of the two chambers should never be happening. Okay, patent ductus arteriosus is a hole. I'll circle these. That one's circled. It's a hole between the pulmonary trunk and the aorta. Okay, and again, it just produces the same problem. You have blood in the pulmonary trunk that was on its way to the lungs, but it's still oxygen poor, and it mixes with the aorta, where it has oxygen-rich blood. Some low oxygen blood is diluting that. Now the brain and the heart, with every cardiac cycle, are getting pulses of lower oxygen blood, and that's a problem. And the last one is ventricular septal defect. A septum is a divider. And in this case, it's the divider of the interventricular. I'll just write it out. It's a hole in the interventricular septum. All right, so that's right there. Same problem. Oxygen poor blood in the right ventricle is diluting oxygen-rich blood in the left ventricle, and when that gets out to the aorta, brain and the heart get lower oxygen, so it's a problem. This, I'm not a cardiologist, all right? I don't know if they give that child a little bit of time to see if it's going to close on their own, and then maybe they keep them in the hospital or in the ICU to monitor them. I don't think they'd send them home with these defects, but if it looks like it's not going to be fixed on its own, they're going to surgery. Little babies going to surgery. Some of these things, which is wild, can be fixed before the baby's even born. They can do surgery on a fetus while it's in utero. All right, which is insane to think about, but that would be if they know that once the baby is born, the septal defect is so bad, it's not going to survive. And so they would go in. All right, but well, anyway, these got to be fixed. And I do ask a couple of questions on these. Okay. The conduction system. I'm going to be asking some questions about this because it's very important. So, the electrical activity of the heart. So did you guys talk about the conduction system in anatomy? Maybe some of you, maybe some of you not. Okay, that's good if you did. The SA node is called the SA node because it's sinoatrial node, or the pacemaker, where the action potential, the AP, in cardiac muscle starts. Okay, and when it starts, it's spontaneous. The heart, the reason we can do heart transplant is because we have a pacemaker in the heart. You can have a donor heart, someone who died, they take the heart, it's healthy. And then they've got a recipient whose heart is not working, and they put them on bypass so that all their blood vessels and circulation of their blood is being handled by the machine. And they've got to take that heart out. Then they got the donor heart. The donor heart's not beating anymore, okay? And they put it in, they hook up all the vessels again. I can't even imagine the skill it takes to do this and make sure nothing's leaking. And then they bathe that heart in a sodium and calcium solution, because both sodium and calcium are important for the heart to contract. And then they defibrillate that heart and give it a mild electrical shock. And all of a sudden the pacemaker's like, oh, action potential, and it starts beating on its own, which is crazy. Okay. Okay. So step one, that little yellow thing is the pacemaker right up there in the upper wall of the right atrium. And an action potential starts in the right atrium. Immediately, step one, part of it, is that AP jumps over to the left atrium. So I'll say AP in the cardiac muscle starts, and action potential jumps to the left atrium, and both atria contract. A lot's happening in step one. The signal starts in the pacemaker. It starts in the right atrium, immediately jumps over to the left atrium, and then they both contract simultaneously because both chambers have to contract simultaneously. Okay, the AV node is this little thing right here in the bottom part of the right atrium. It's called the atrioventricular node. Is where the action potential pauses briefly to allow time for the atria to contract. What you want to have happen is time for those atria to contract fully, to push all their blood into the ventricles. And once that happens, then the signal can go down to the ventricles. So then it is step three, is where the AP is is in the interventricular septum. It's on its way to the ventricles. And then the last step, step 4, the AP is in the ventricle walls, and they contract simultaneously. So these are the events that are happening, and it's pretty quick when you think about how quick a blood does, all right? Okay. How do you look at the heart's electrical activity system? What device do you use to look at the heart's electrical impulse system? It's kind of, what's that device called that gives you a reading? EKG, all right? It's also called an ECG, but EKG. You're actually looking at the timing of these events happening, and that's important. It's going to be on a computer, and you can measure the time that it takes in milliseconds for a signal to get from point A to point B and the electrical activity that's actually happening in the hearts. Okay, so here's kind of what it looks like, all right? Starts in the pacemaker, and they don't show, starts in the right atrium, jumps over to the left atrium, they contract simultaneously. Pauses briefly at the atrioventricular node, then goes down the bundle of this, then to the Purkinje fibers when the ventricles contract simultaneously. All right, so I have another little, if it shows up, this is more like it, all right? See how it starts in the pacemaker and immediately jumps over here and they contract? Then it pauses ever so briefly, then goes down the septum and into the Purkinje fibers, and then they'll contract simultaneously. It's a very quick event. Right, but the timing must be perfect so that when the atria contract, they do it simultaneously. When the ventricles contract, they contract simultaneously. When the valves close, they must close simultaneously. All of that is being controlled by the conduction system. So you have to have a way to measure it to see if someone's heart is not functioning correctly. If someone's pacemaker is faulty, what can you do to fix that? They can have they can have an artificial pacemaker put in, okay? And that's under their skin, and those are the people that can't get an MRI and all that stuff. That's how important a correct functioning pacemaker is and how all this electrical activity is. So your EKG, all right? There's a P wave, and then you have a D dip down here, QRS wave, and then a little T wave that follows that. Okay, so here's what's happening with the P wave. During the P wave, you're looking at the atria contracting. Okay, so the atria have already filled with blood. They pushed open the tricuspid and bicuspid valves, and blood is actually filling the ventricles. So really what's happening here, ventricles filling or filled, because when the atria contract, the ventricles should be now full of blood. Okay, and then somewhere in here, the bicuspid and tricuspid valves will close simultaneously. All right, after the P wave, after they've contracted, they're going to close, because the QRS wave is when the ventricles are contracting. Okay, that's going to be ventricular systole happening there. Okay, when the atria are contracting, that's ventricular diastole. That's when they're filling. Now, the T wave right here at the end is when the ventricles are relaxing. And then they're starting to fill again, and the whole process repeats itself. The ventricles fill, and then the atria contract and eject their last little blood into the ventricles. And then the AV valves close, then the ventricles contract, eject their blood into the semilunar valves, and then somewhere in here, the semilunar valves shut. So it's like lub-dub, lub-dub, lub-dub sounds. Now, you can't write all this down. I can't possibly test you on this, but I'm trying to explain to you how you overlap what's going on in the heart during the conduction system. And then when you look at an EKG, what these events mean. Okay, so I always tell this story because, well, I've got stories. How important are these EKGs and what you're doing? Very important. So there used to be an instructor here who taught anatomy. He's not here now. But he was teaching some of my physiology labs because I was training him to be another instructor to teach the human physiology for nursing students. And so in order to learn the labs, he would attend my early lab in the week, like on a Monday. And so then when he had Wednesday lab, he had done the experiment and knew how to work the equipment and all that stuff. And so we were using kind of like what you're using in lab, a device that hooks up to a sensor. And we were looking at EKG. So we had the EKG sensors, all right? And so he was learning how to use you use this LabQuest device. So we had something different, but he was learning how to use that and then collect the data and measure the waves and the time between them and all that stuff. And so, it's supposed to look like this, an EKG, P wave, QRS, and then a T. It's 3 distinct waves. And so I'm working with my students because they're trying to learn it too. And then he comes over and says, I'm not getting the right wave. There's something wrong. And I said, well, let's see if your sensors are hooked up correctly. It's just a sticky glue that holds them in place. And sometimes they come up. And I said, well, maybe your wires are tangled. So I tried to untangle his wire. I said, okay, well, maybe it's this. Maybe it's your, LabQuest device, this interface. Maybe I'll try another one. Let's put that one and see if that works. Oh, no, it's not that. So let's try running me on this same setup. And I get this beautiful PQRST wave, all right? And so we kept trying and trying and trying it with him. And no matter what permutation of change this, change that, change, I kept getting the same thing. His EKG looked like this. He had a little P, he had QRS, and then like no T. And then it was like he was missing a T. All right. And finally I said, I've tried this every which way I know how. And I said, I think this is actually real. I think you should see a doctor. He did. He went to McLeod. They said something's not right, but they didn't feel like they had enough experts there to really, they couldn't figure out what it was. So he went to Duke and finally got diagnosed. He had cardiac amyloidosis, where abnormal proteins develop in the heart and it makes the heart an inefficient pump. And he also had these other symptoms. When I first said, I think this is real, he was also saying, I jog and, you're supposed to get better with jogging. You're supposed to get conditioning. He says, I just get more fatigued. He says, I get winded walking from the parking lot to the science building. I said, yeah, this is not right. 3 weeks after his diagnosis, he died. Right? His heart was not functioning anymore. He was told to rest. And he was bed resting, basically. He had to get up to go to the bathroom. Thank God his family was there with him. He got up, he had formed a clot in his heart. When he got up, clot went to the brain, he had a stroke. Just like that, okay? These things that you're measuring, they're important. And when you see something or hear something wrong, it's important. So if you're the one who's doing the workup on the patient to give the doctor information, all these little things are important. Okay, so yeah, this stuff actually happens. Unfortunately, I'll never forget it for the rest of my life. Okay, I was like, God, if he'd only taught it earlier in the semester, maybe he would have had time to go to his doctor and could have caught it, and whatever the would haves, could haves, should haves. But yeah, it's tough. So, well, anyway, not to bring you down, but I want to encourage you that what you're doing is very important to people's lives. Okay, quick review. Sympathetic innervation of the heart's pacemaker, okay, with thoracic tension up nerves and then the cardiac's own nerves. What's the sympathetic neurotransmitter for the heart and the whole body? Epinephrine. What is the receptor for epinephrine on the heart? Beta 1, adrenergic. Okay, and that causes heart rate to go up. Very simple. Now, if it's parasympathetic with on vacation vagus nerves, that neurotransmitter is always going to be for the entire parasympathetic system, acetylcholine. What's that acetylcholine receptor on the heart called? Because you have no control over the heart, so you must. Okay, and that makes heart rate come down. Can't let this stuff go. I keep coming back to it over and over and over again. Since we're talking about the heart, it's electrical system, measuring the electrical system. And then what happens if you have a patient who has abnormal heart sounds, the valve problems, or what happens if they have abnormal heart rate? That's what I'm getting to. Okay, and it builds in some nice review of material we've covered. So continued review. If the heart is stimulated, the two stimulatory ion channels are what? Sodium, and it's both sodium and the other one is calcium. Technically, it's calcium +2. All right, that is going to stimulate the pacemaker. Here's what's happening. Epinephrine binding to its beta-1 adrenergic receptor on pacemaker muscle cells will increase the rate of contraction. Okay, so the increased rate happens at the pacemaker. And then the rest of the conduction system just follows the lead that the pacemaker gave. So if the rate goes up in the pacemaker, then it goes down to the AV node, the bundle of His or kidney fibers. The signal is faster because of the pacemaker has been set and influenced by epinephrine. The opposite, if it's parasympathetic control or the heart muscles are resting in the pacemaker, that's always going to be potassium channels. That means the pacemaker contracts slower, and that slower rate is followed through the rest of the conduction system. It's all controlled at the pacemaker, and those neurotransmitters control how fast the pacemaker depolarizes or how slow it goes. All right. Okay, so that stuff that you've learned, it's going to come back. It's going to come back in pharmacology. It's all important. So now you're looking at an EKG, and you can certainly tell heart rate by an EKG. Because the easy way to do it is to see how many QRS waves you have in a certain time interval. It's like measuring your pulse rate in lab. If you count, let's see, 6 QRS waves in a 10-second interval, what's the heart rate? 6 waves in a 10-second interval. It's like 6 pulses in a 10. You take 6 times the, 6 times that. Okay. So that would be actually really low. So I'd have to be higher than that. But that's how you can do it. Okay. And it's all on computer now. So it makes it really easy. Now, here's a nice normal heart rate, whatever it is. If you have a couch potato person, the resting heart rate could actually be 80. Okay. If you have an athlete, it could be as low as 50 beats per minute. And that would be normal for them. Okay. All right. What happens? And I have a clinical app for that, which I'll let you read on your own. What happens if you have a tachycardia? That means what? Higher than normal heart rate. The person's sitting and relaxed, and they've been sitting and relaxed for the last 20 minutes, and their resting heart rate is very high. That's going to lead to high blood pressure. And whatever the heart's doing, the blood pressure follows. Over time, you will actually wear out the heart. The heart will thicken and become what's called cardiomyopathy because it's being overworked. And so that becomes permanent damage. And then, of course, chronic high blood pressure causes all kinds of problems. So you must bring that heart rate down. You must bring the blood pressure down to not put so much work on that heart because it can become overworked. So we know that in order for the heart's pacemaker to depolarize more frequently, you got to have both sodium and calcium channels open, like epinephrine binding would do that. If you give them, and don't memorize these drugs, not for physiology, okay? I want you to know the beta blockers because they're so common, but here's a couple examples of sodium and calcium channel blockers that will basically keep those channels blocked, so the pacemaker has to be slower. All right, now beta blockers review. What's the general beta blocker that blocks the beta-1 adrenergic receptor on the heart, but can also affect the beta-2 receptor on the bronchioles and cause your bronchioles to constrict? So it'll bring heart rate down, but it can also cause the bronchioles to constrict. That is the first one developed, kind of the cheaper of the 2 different drugs. I'll give you a hint. Propranolol. That's not the drug you want to give to someone with high blood pressure who also has asthma or COPD or bronchitis or COVID, because you probably kill them or put them into respiratory arrest, which is not good. If you have someone who has high blood pressure or high heart rate, which could be causing the high blood pressure, you want to give them the beta-1 specific blocker, which is atenolol. All right, because that'll bring the heart rate down. So it fixes the tachycardia. It brings high blood pressure down, but it doesn't cause bronchial constriction. It's good for someone with asthma or any kind of respiratory problem. All right. Okay. The opposite problem, and this is less common, is lower than normal heart rate. Okay, someone's heart rate could be so low that they pass out frequently. All right, well, every time they go from sitting down or laying down to standing up, they pass right out. Okay, now what you want to do is increase the heart rate or make the heart, when it contract stronger so it ejects more blood. So let's start with the ones you've learned. A beta-1 agonist that stimulates the beta-1 receptor on the pacemaker and makes the heart beat faster. Dobutamine. Okay, how about the MAOI class A? What will that increase? What if we're talking about making the heart rate go up? What is MAOI class A an agonist to, or will cause increased levels of this neurotransmitter that could make the heart rate go up? Start you out. Oop, no, go away. It's giving me a hard time because I'm close to that. Epinephrine. It's an agonist to serotonin, yes, but also epinephrine. Digitalis is a new one for you. It makes more calcium available to the heart. So when the heart contracts, it contracts stronger, and that will make more blood leave the heart when it contracts. All right. Bless you. So almost everything here is review, although I never ever listed these drugs before. But the new one is digitalis. Okay. So now that you understand how the heart works, and I've talked about neurotransmitters and the receptors, now I hope that understanding these drugs, even if you don't know their names, but you know what they do, you now understand how they're fixing the problem. Okay. But again, this is an introduction to kind of nursing pharmacology, just introduction. Okay, let me check my time. We're okay, got a little bit. Blood pressure. We'll go over this, but we did it in lab yesterday, so I don't have to go into a lot because you had no quiz, but anyway, we looked at it. So systolic blood pressure is the upper number. That is representing the pressure in your arteries when the ventricles have contracted, especially when the left ventricle is contracting, because the left ventricle is bigger and thicker. Okay, and of course, our range is 80 to 160 for systolic arterial blood pressure. All right, your diastolic is the pressure when the ventricles are relaxing, and that's going to be your lower number. And then in terms of measuring it, I showed you this in lab, so I don't need to show it to you again. And you've now heard Karatkoff sounds. And then this video right here is really actually good for going over that again. But I don't feel like we have to here because we just did a whole lab on it. So, and this is the diagram that I had showing you what's happening with the cuffs. When your pressure in the cuff is high, you're actually squeezing the brachial artery closed. And then when you crack that knob a little to the left, the air starts escaping, now the blood can start moving through the brachial artery. And if you hear the sounds, first time you hear the sounds, that's your hearing arterial blood now squeezing through the artery. You look at the gauge, that's systolic. You keep listening, the Karatkoff sounds get a little bit louder, and then they start to trail off, and eventually they stop. And then you look at the gauge and you record the diastolic pressure. So now you've all done that. So, all right. This is probably a great time to take a break before we get into the next topic, which if I have a star on it, it means there's going to be exam questions on it. Okay, but it is like 10:49. So let's take our break until 11, clear our heads, and then continue on with this.